Good afternoon and welcome to Zahn Academy. Today's webinar is on GC LiSi Press, an aesthetic approach to combine digital with analog dentistry. Our speaker today is Alexander Wünsche, CDT and owner of Zahn Technique Dental Lab in Miami, Florida. We will be taking questions at the end of the webinar, so please, you can type them in at the bottom of your screen and we will get to them, like I said, at the very end. I hope everybody enjoys today's webinar, and here's Alexander.
Yeah, thank you so much for the introduction, and I want to say thank you to GC for having me today here, and also to Zahn Dental for organizing the webinar today. So I'm very happy to be with all of you today and talking dentistry, talking dental. I think everybody's like used to that scenario now, right? To sit in a computer and watching or seeing lectures and presentations online. I think we're all used to this now since over a year in the pandemic. And I was really happy over the last few weeks. I was able to now go out and have live presentations again, which is the most fun. But nevertheless, I love also to just sit in my surrounding here in my laboratory today and take an hour off and just share my knowledge and share my ideas with all of you. So let's start. So the topic today is basically, I was just saying creating smiles. That's all what we do all day, right? All day, all year round. And I always say as dental technicians, we are 24/7. There is not really a 9-to-5 job for us, at least not for me. So we're passionate creating smiles. So if I go back, right, let's say 25 years when I started as a technician, creating smiles was really quite different than nowadays. And if I think about when we started creating smiles, there was no digital at all. So we kind of started seeing some CEREC machines coming up and some intraoral scanning and chairside milling, but it was all pretty clunky in compared to what we do now. And now if we are looking into what we're able to do, it's pretty cool. We can say we can do the fully digital restoration. And it's just like a simple full contour zirconia crown. In my world, not really pretty, but if you look at this, the anatomy is not like a tooth. The color is not like a tooth. And also in the mouth, seated, it doesn't look like a tooth. Is it functional? Absolutely. You see on the right side that photo with that little amalgam filling here. It's a filling. It's also functional, but it doesn't look like a tooth. And I was always bothered by that scenario we have now running into the digital dentistry road, and we love what we do, and we do that, and we are happy. Oh, but now we can print the models, we can mill a crown, we can glaze it and just ship it out, even model free. It's all nice, right? But for me, in my world, and my team, when we ship or when we send cases out, it has to be a tooth, not a crown. And I'm just not satisfied with what I'm seeing there. So for me, I like to combine the digital world and the analog world together to get the really best outcome of both worlds. And so for me, always was the idea, how can we make digital more natural? And that doesn't mean we go backwards. So back basically to the roots. Now we want to combine, we want to actually be more advanced to get to that natural effect in a more progressive way. So how do we do that? Of course, with materials. I will talk a little bit later about that. But before we even go into materials, before we even go into a case, in a digital case, we have to know how to treatment plan a case. How do we treatment plan a 8 or 10 unit veneer case, for example? An anterior case, a full mouth rehabilitation. How do we know what materials do we have to use without any analysis before? And usually in my world, I start every anterior areas, every aesthetic case with a facial analysis. And when we look at the face, on a human face, we know, or I assume you know, and me too, a face or a human being is not symmetric. Why? Because symmetry in nature doesn't exist. And if you look at faces, and we make a quick exercise here, we can do that on Keynote or on PowerPoint, very easy. We just have the face, the photo of the face, and mirror that photo, duplicate it, and put it to the other side. We realize, man, really faces are not symmetric. So we realize actually that these two face halves creating a different face all of a sudden. On the left side, we see that patient is actually, his left side is less dominant, his right side is more dominant. So if you put both sides together, we have more like a computer nerd on one side, on the left side, on the right side, we have more like the football quarterback. And that's like very interesting. And that's very interesting or very important to know for us when we do start analyzing the face. So why is it important? Very easy, very simplified for the midline, for the buccal corridors, and so on, to not go very stubborn just with the midline of the pupil space, you go down there, or the nose. A face is not symmetric, so we have to kind of evaluate that. For that, we need to know what is the dominant and the less dominant side. So for this, we need certain photo records to do. Usually I work with the rest, the smile, and the retracted photo, and many more. For example, I work with a 12 o'clock shot. This gives me more the 3-dimension of the face, right? I see how is the face curved, the mouth area curved, whereas the nose in relationship to the incisal edges, the upper incisal edges. I need a retracted close-up photo, and that I need basically to look into these little things what the patient maybe does not know really how to explain what they don't like on their smile, on their teeth, but I can evaluate it. I see here we have that reversed V, for example, the teeth are worn. I see, for example, we have black triangles, so the papillas are basically recessed, so we want to fill this again. I also see there are uneven tissue corridors or tissue levels basically, where I know, okay, I want to kind of level this out maybe to make it perfect. So that specific patient just had the idea, I made him an implant crown and posterior, and he said, well, I want to have your teeth. And that's how it started with him. So he said, well, I want to have your teeth because I don't like my triangular shape and the black holes I have in there. So I said, well, let's evaluate it, right? So we started then putting everything together in a digital design. So we imported all his records, including the models we scanned. We also could have used intraoral scans and merged them together. So how does it work? I will show it a little bit. I will just kind of go that case in kind of in a quick run. We just have an hour, so I have to kind of talk a little bit faster and move along. So we see here we have the smile, the retracted view, and then we putting basically molds into the digitally molds into that view, and we can refine that, and we can send that patient our proposal. Say, hey, that could be your smile. Do you like that? And he saw that. He saw how everything built up, and he said, that's what I want. That's exactly what I want. So can you do that for me? So of course. So we then started on the same time, actually, move back a little bit. When we do that smile design, we actually have a split screen, and you see this a little bit later, where we on one side design the smile in 2 dimensions, but in reality we're putting all these teeth in 3 dimensions on these STL files, what you see here. So we're actually making a digital wax up with his photos in mind, with his photo in the game as well. So yes, I thought of course we can do that because we already planned it very properly the right way. So we see here then, let's move back one more slide. You see here then on the digital design, that gets printed. The doctor can use it as a prep guide, and then we're getting the prep impression, the impressions of the preparations, or the intraoral scan, can merge that together to the same case and can start designing basically the crowns into our diagnostic wax up we made from the digital smile design. These crowns, we then can basically start finishing. So we milling them, I mill them in wax and then invest them and press them in GC LiSi. Why GC LiSi? I will also explain in a few later slides. It's just a very high-end lithium disilicate for very nice and highly aesthetic cases. On this case, we realized throughout the process that we have to do some tissue surgery in these 2 teeth. So the patient at that point got a little provisional bridge here, but nevertheless, we could also start and finish the other crowns. That made it possible. And here you see the final result. You see the temporary bridge fits nicely in shade and color to our final crowns. So that's the final result, and the patient was really happy with that. I'll show you a final photo comparison. Basically, that's what he wanted. Yeah, it's all aesthetic is a matter of taste, of course. So that's what he liked to have, and that's what he got, and he's very happy with that. You also see on the left side, you don't see it really, but you see his hair is long on the right. So I was through the pandemic last year when we finished the case. So he just let his beard and hair grow and grow and grow, like we all, right? If you had seen me a year ago, I had long hair like this, so now it's short again. So anyway, so you see here the whole flow from up down. You see the starting situation, the design or the planning, and you see the final. So that's kind of what we can do nowadays with digital dentistry and with digital materials and digital workflows equipment. But what I do here too, I go back a couple steps and make a lithium silica restoration. I'm milling it on wax and press it. So to get there, sometimes it's not as easy. He was a very easy camper. He came in, I want to have your teeth, let's get it started. He was all sold in. So sometimes patients are not sure, right? Or a dentist says, well, I have an idea. I think you need something different in your smile. Let me help you. So we have that, we call this the emotional smile consultation. So for example, this patient here, you see multiple different colors, different levels of tissue. She's a very unique character, we'll see in a second. And so we had an idea to give her a different smile. So we did the same thing. We did a digital smile design on her, also in 3 dimensions, and created a digital model and a silicone matrix to make a mock-up in the practice. So the doctor here is able to now put that, our idea of the smile, in the patient's mouth with a acrylic-based drying material, temporary material basically, and Luxatemp, for example, and can test run the case. Important is, do not give the patient a mirror. That doctor did not give the patient a mirror, just the doctor told the patient, hey, just look at my phone, tell me something. The patient said, hey, I want to sing. Just give me some music, like here. Let me turn this down a little bit. So the patient just started singing, and the doctor recorded it. And so at the end, the doctor showed the patient the movie or the little clip, right? So she never saw it before on the mirror, just in her little clip. Watch this.
It's magic. Look at my teeth. Oh my God. Oh my God.
So you see, the patient reacts very emotional because she was living all her life with her teeth. She actually did like, she even didn't want to smile really. Now she sees that, and to see on the left side on the photo, when she was smiling in the camera, she has a very positive posture in her face and in her lips and her mouth. So she likes to show it. She feels already there's something different, something positive. That's the emotional smile consultation, how we call it. A very good tool for the doctor in the practice to show patient how we can improve their smile. So now the next step before we go to final, what we saw at the beginning, right? So I'm going a couple steps back now. How do we temporize patients after that smile design, after we know where to go in 3 dimensions already? How do we temporize them to make everything secure, vertical safe, and we actually can copy what we have in a computer on the picture for the patient now in the mouth? So this patient is a very good example for that to show. You see here, she has a very collapsed smile, very collapsed bite, because she is missing her maxillary posterior teeth. She already got implants in, so you got 4 implants, 2 on each side. And the plan is to restore her with 6 anterior crowns, 2 3-unit bridges in the posterior, and in the lower veneers and crowns for the lower. We want to open her bite roughly 5 millimeters. That's what you roughly lost over the years on vertical, to basically reestablish a proper occlusion. So how do we do that? We do the same thing. We do a digital smile evaluation in 3 dimensions and creating a digital wax up with her smile in mind. You see here already in translucent wax up, you see underneath her current situation, you see how much we actually open the bite and lengthen teeth. And we want to now transfer this to the mouth. So we're going to utilize, you see different angles of that. So her implants were uncovered. The doctor took an implant impression, send an impression to us. We made a model on that base. We also could do an intraoral scan, and we merged that record together with our digital smile design, with our digital wax up. That allowed us now to create, that's the initial situation, that's the wax up, to create here 2 3-unit bridges for the posterior and a temporary shell for the anterior. We just basically merged this together and designed into that diagnostic wax up. Also, to seat everything together with full control over position, vertical and aesthetic, we created a little seating guide, what you see here, over that new design basically. So here you see it in big. The design was saved as an STL. We designed the seating guide or the kind of seating jig and printed that. Here the quick print of the teeth. Here we milled the shells. We milled the PMMA implant bridges, bonded to titanium bases, and here the multi shells in a different view. Here everything together, and here you see how everything fits nice in that seating guide. On day of seating, we basically go back to the patient's mouth. The doctor's prepping the anterior teeth, seating the posterior bridges. Remember, these are an implants, so implants don't move. So these actually are giving us the perfect relation to our planned vertical and our planned occlusion. And then all what the dentist has to do is retrofitting the shells over the preparations, what you see here. So taking off the shells a little bit, taking off the preps a little bit to make sure everything sits nice and passive. And here different view, and then the dentist can place that shell with that seating guide, which is resting on the posterior bridges, nice in place with full control over aesthetic, vertical, and function. Everything is seated as we have it planned digitally in a computer and fabricated basically. So that's a very easy way to do. A little more tricky is if you have no implants or just one implant maybe in all teeth, right? In this patient, for example, we had to do a full mouth rehabilitation. So we did upper and lower. On the right side, we see it, the temporary. How did we do that? We did the same thing. We made shells, and then we created 2 seating jigs. So we basically seating these shells in stages. So the doctor first preps the posteriors, and the shell fits over the current anteriors and then over the posterior preps. And then we reverse it basically. The second seating jig fits over the new posterior shells and the preps of the anterior, and it can be seated. Same scenario, just with 2 seating jigs, but also keeps full control over everything. And then we see here the final result. So this is kind of a very typical scenario how we solve aesthetic problems or keep aesthetic control over a case. So now actually I have to cut this out. This is too much today. I'm sorry for that. That was supposed to be minimized. Otherwise we come not through today. 1 second. Another important thing is after we have the temporaries done and the patient is happy with the look, we're doing a shade and aesthetic communication. The next thing, right? How do we communicate shade? How do we communicate actually that we can make a decision what kind of material we can use, that we're going to use lithium disilicate or maybe zirconia. So that's very important to make that evaluation early on. So to do that or to fabricate monolithic aesthetic crowns like this in a posterior area, they're really fitting nicely in and blending into the whole scenario. By the way, the crown is here, so it's really blending in nice and has a very natural look. Again, I'm trying to fabricate teeth, not crowns. Is very important, so we have to evaluate the case. To evaluate a case, the first thing what I have to know as a technician, what's underneath, right? Do we have vital teeth underneath? Do we have maybe root canal teeth underneath? Do we have metal posts or abutments or implants, basically? So it's very important to evaluate this properly. So in this case, for example, here we're doing a 300 bridge, right? So this tooth is a vital tooth. I would say a good stump shade if you consider the surrounding shades or color of the teeth. This stump is a root canal. So it's already a red flag. So that already, at least in my world, kind of takes out several materials I cannot work with. all the materials that are too translucent would not be qualified for that case. So for this case, I would not choose a lithium disilicate. For bridge anyway, I'm very critical about that. But even if it would be a single crown, individual crown, I would choose a zirconia, or even PFM, what allows me to mask all the underneath color, and I can full control over the final look basically. So here we did a porcelain fused zirconia bridge nicely, and it blends nicely into the mouth. I did this case with Miles Cohn, Dr. Cohn, in Portland. So he's a phenomenal photographer. So I'm very happy to show this here. It's a really nice intro photo, and you see the shade. It just blends nicely in. It's like the next door neighbor. You know, it's a normal case, nothing special. Another little shot of that. So another case, yeah, we're looking into this shade communication again. So how do we communicate shade? I love to use a 3D master from Vida. That's kind of my usually go-to shade guide because it gives me the best differentiation between hue and chroma and value, and I can just look into what I usually tell my customers. Hey, take the most close shade you can find and show me it close to the next tooth. Make sure it's in the same angulation and the tooth, and it's ideally even touching the tooth or just in the same, almost touching. Choose a shade lighter and a shade darker. That's kind of how I tell doctors to take the shade. If there are multiple colorations, like in this case, I tell them all, look at incisal, show me the closest incisal shade, show me the closest body shade and the closest cervical shade, and I can basically start establishing that tooth. So in here, the patient got 2 new crowns on the premolars here, and the expectation was copy what I have. So definitely very colorful, right? So we started basically doing 2 monolithic lithium disilicate crowns, and here, boom, here they are. There's nothing layered, they're just stain and glaze. And you see this is really very, very close to the surrounding dentition, and the value is almost there, the color is definitely there. So that kind of is possible just with stain and glaze, believe it or not, with the right communication from the clinician about shade and coloration. And by the way, these are medium translucent, empty ingots. That's what I use the most of the time. I use from GC LiSi, most of my restorations are MT, except the veneers. I utilize usually the enamel ingots, the HT. I very, very rarely use the opacity, more opacity ingots, and I usually go to a different material. So how do we make a monolithic restoration pop? With effects, right? These effects are our key basically to make a restoration look natural. And effects are usually light and texture. And light and texture usually are, texture especially are our line angles, our lines, if they have lines, our mamelons, basically it's all these things that we all can look into the neighbor or adjacent teeth to look how much we can do or put on the surface. Why? Because I always say less is more, and it doesn't make any sense to make a beautiful tooth with a lot of texture, like of a 17-year-old teenager or 16-year-old teenager. It looks just gorgeous, and next to it, it's just a completely flat, natural, old 55-year-old tooth. Doesn't make any sense. So we have to always match that surface texture to the adjacent teeth. The other thing is light, right? Or sorry, a couple slides of this here, texture again. I utilize, for example, these powders or these little lacquers. They're easy to steam off. They're from Harvest or from MPF, and they give me a lot of information. For example, in this case, I have 1 veneer and everything else is natural dentition, and the veneer is number 10. Yeah, so I was able to really match this surface texture and line angles and everything very close to the adjacent teeth, just also with help of these little lacquers I can use there. It's really cool tools. Light, very important. This is a lithium disilicate restoration. Light goes just really beautiful through. That's how a restoration should look. It almost looks layered, right? But that's how it should be if we have the right underneath structure. If you have a stump or a preparation is just half the size of the crown, I have to play a different game. I will show this in a second. So here just zirconia restorations, just I want to show light reflections, texturations basically, how we can make things natural. For me, the biggest challenge is definitely lower anteriors, to have that nice tapered look with the line angles. That's challenging too to do, yeah, to make it natural, to really look good. Here, anterior crowns, just to show different shapes and different texturations. That's a zirconia. I just want to show the linguals also have texture and anatomy. It's very important. Yeah? We cannot forget about the linguals. There's some function behind that. Some wear, some movements, excursions. Saliva has to flush out from the tooth. So it's very important to also give the linguals some anatomy. That's an exercise I did throughout the course. There's a layered and a monolithic crown here. So I'll usually ask, what do you think? Is the layered? What is the monolithic crown? I'll just show the slides here through, and it will show you which one is layered, which one is monolithic. Yeah, so number 8 is monolithic, and number 9 is the cutback crown with layered porcelain. It doesn't matter the material. It's just amazing nowadays what we're able to do with our progressive modern high-end materials to be almost as close as a layered crown with a monolithic material. Do I want to really match a number 8 to number 9 as a natural tooth as a monolithic crown? It's going to be hard. Yeah, as I always usually go with a micro cutback to put some effects in there, or even more of a cutback depending what I have to match. Here you see all the things here what I put on. Important is not just the tooth structure or tooth texture. Important is also what kind of base we have to work on. Our base is the model, right? And I want to show here different model materials in digital dentistry. This is a milled model. A milled model doesn't really give us a lot of information about tooth texture and anatomy. It's very important to understand. So if I'm, for example, have an iTero machine or an iTero scanner and I'm getting iTero models, they are milled. Then I have to definitely ask the doctor for a good photograph of the texture with good lighting, that I understand how that adjacent tooth looks. Or I maybe have to print me a study model with a printer to get a little bit more information, yeah, about the anatomy of the adjacent teeth and of the tissue. It just has some more information, and I'll show you this in a second. Or I'm asking the doctor, hey, can you still take an alginate just to get information about the model? This is a stone model. Look at that deep, that refined and fine contouring, and you see basically everything in a tissue what you want. So that's important for aesthetic restorations to see. For us, the tissue architecture, gingival architecture is very, very important for aesthetic restorations. Here, a printed model, much more detailed than a milled model. I don't want to say milled iTero models are not good. They are phenomenal because it's super accurate. But in regards aesthetic, I most likely have to then print me a second model just to be able to see all the texture and anatomy on this case. So here we see a resin milled, stone, and resin printed. So now next case, it's a very typical case what I do. We have an anterior case to do. You see they're really in bad shape, and the patient kind of has the idea, I want to have a new smile, improved smile. So we're doing the same thing except we did before, a smile design. We make a proposal and we go through the exercise here on this picture. It's just a quick planning to give the doctor the idea, where do we have to maybe prep more or cut more tooth structure, what we maybe can leave even in untouched, just in an enamel. In this case, it's a veneer case, so we definitely want to be careful that we're not prepping too much. We try to stay in the enamel for veneers, right? So we want to be minimal invasive. For a patient, look, I can remove these teeth and just give him, okay, that is your smile we're looking into. That's the future outcome of that restoration. We then fabricating a model. The doctor can use it with a stent for temporaries. We can make shells, whatever basically your customer is asking for. The nice thing here is what we usually do with the clinician here, that's Dr. Perry in San Francisco. We're doing these cases a lot together, and he's really, really phenomenal in evaluating a smile and showing me exactly what maybe has to be improved for the final. We see here, for example, the temporaries are in. I say, Alex, number 8 is a little bit too long. Number 7 is slightly too long. This is my corrected horizontal, what we are working here with please correct this for the final. It's fantastic. I can import that photo in my final design. I can have the scan of the temporary basically imported into my design software and can adjust my design exactly to that kind of number. We have to make that shorter or longer to establish that perfect smile. And then I'm creating GC LiSi crowns as we did here, or veneers. Crowns, that's a mixed case, by the way, crowns and veneers. So here, these are monolithic restorations. There's nothing layered. So we're just staining glaze basically with some effects in there to create that natural look. And here we see the final outcome. The patient was very, very happy, and he can't wait to do the lower now. So that's kind of how we work, and it's a very, very straightforward to work like this if you work very close with your clinician. You see, usually I put a little bit of kind of orange here and incisals just to give that vital look, to give them a little vitality to the teeth, and they came out really natural and nice. So when we talk about lithium disilicate, we have to understand, or generally modern materials, we have to understand material properties. When I explained at the beginning, when I started 24 years ago in dentistry, material properties, what we utilized, the materials back then was quite different than what we utilize now. And before I go to the next slide, I just want to mention, when we work with progressive materials nowadays, it's actually much more difficult than when we go back into PFM restorations or composite restorations. Why? Because our progressive materials are gorgeous and they're fun to work with, but they're very sensitive. What I mean with that is, if we have a zirconia framework, it does not fit, we have to redo it. We cannot cut it and solder it, what we do with the PFM framework. A metal framework, we can cut, solder, and we're good to go. On a zirconia, it does not work. On a polymer bar, for example, if that doesn't fit, we have to redo it. Zirconia hybrids, if they break, we have to redo it. So most modern materials are literally not really easy to repair, or are even impossible to really fix or repair or correct. So we have to be very, very correct in our workflows. Therefore, that's also a pro argument for smile designs, for the evaluation, for proper treatment planning. We cannot just jump in a case and think, oh, it's going to be right. It's not. Yeah, so that's very important. And we have to know our material properties. So if you compare lithium disilicates on the right here with zirconia on the left, we have to know how strong are these materials, what's the translucency of the material, and so on, and how does our clinician has to actually treat the material in the mouth to make it really bond properly to the tooth. Yeah, and you can read it. I don't want to go deeper into that because we want to concentrate more on the lithium disilicate section. Also important is there what I already mentioned, the translucencies. Lithium disilicate has a call, oh, it's low value, it looks gray. And I would say that that's not true. If you work the material the right way, and if you utilize the right lithium disilicate, it is not. That's the reason why I use GC LiSi. GC LiSi, I can assure, is not gray, it's not graying. It keeps the color over firing and firing cycles very, very true. That's what I like in the material. That's why I use it. And I'm most of the time are in the MT section, the medium translucent section, and the HT, the high translucent section, which is usually the enamel ingots. So when I do a veneer case and we stay in the enamel for the preparations, I use the E ingots, the HT ingots. If I'm more into dentin and I have a more kind of aggressive preparation, I go with the MT, because I most likely have to cover some of a darker, warmer tone from underneath. It's very important to understand. Also, treatment of different materials. We consider lithium disilicate here. I usually divest it with glass beads. I usually avoid sandblasting, aluminum oxide. I do a little bit at the end before I etch it. Yeah, and of course we can etch it before the case gets bonded into place onto the enamel. As it's very important. Compared to zirconia, they need quite a different treatment. I'm gonna skip over that. So monolithic versus layered, I already mentioned a couple things or showed cases that are monolithic. I really make a case dependent and really look at the case, look at the color, look at the patient expectations and make a decision. Are we doing a layered case here or monolithic case? And then I consult my customer in that direction, what would be the best for that case. On both, we have a very consistent color results. We have a very good bond of the porcelain to the lithium disilicate, which is great. So it's really depending on the coloration, on the shade what we're looking for, on the vitalization or on the characterization we're looking for. Important is to understand that lithium disilicate is not lithium disilicate. There are differences. For example, there are more I would say the generation 1 or 2 or generation 1 lithium disilicate. They're more, as my experience is, more on the rough side than, for example, GC LiSi, which is basically we call it the HDM technology, which is a more denser, finer, and I would say more cleaner material. What I realized that is when I press it and I adjust margins very thin, I don't get any chipping, flaking, or any porosities in compared to other materials, other lithium disilicates. So that's kind of what I really enjoy working with that material, just because the end result is much quicker to achieve and much more consistent to achieve. That's really what I like. If I go now into firing cycles, I can fire that material, glazing it multiple times, or even layer porcelain multiple times, more than when I compare this with other comparable materials. They then have actually that value loss, or they're going more gray basically. So that's important to understand. A case like this, I still can cover metal custom abutments. Now you can say, oh, it's gold colored. It helps, right? Yes, it's gold colored, but still the material helps to cover the metal, because I found out over the time that the anodizing or making an abutment gold doesn't really help a lot, to be honest. Metal is metal, and it will always show at some sort to the tissue if the tissue is very thin or the material chosen over it is not really blocking it enough. So that's kind of a lithium disilicate case as well. The 7 and 10 are veneers, and 8 and 9 are crowns, and also GC LiSi case. And I used actually here MT, and MT was enough to block out that gold colored abutment from underneath. You don't see any color difference to number 8. So that's kind of really cool. It was a very nice result what we achieved here. That's the case I wanted to show you what to do with something like this, right? When the doctor calls you, hey, I'm sending you a veneer, and by the way, it's going to be tricky, just check it out. And the model comes, or the scan comes in, and you see this, you say, oh, here. So now you can say, what? What's the problem? Just do a veneer, right? The problem is the area between that incisal of that prep and the actual incisal of our veneer we would like to have, which is down here. So this whole black hole here is just air. There's nothing in there. And what happens if you're doing now a veneer, and I mentioned already, this is all enamel. I like to use an HT enamel ingot, because that will replicate this enamel of that neighbor tooth the best. So what do? I definitely design my veneer in full anatomy here, because I would like to have all my buccal surface in enamel, in pressed enamel, also for stability, because this will be super thin here. This is maybe 2/10. So I wax it full anatomy. I then scoop out the lingual of that area here as thin as possible, because I have to establish now that shape, or that stump, basically that the dentin. I have to establish it from the lingual. So I'm gonna basically scoop it out. I've fitted everything on the model, and I'm layering porcelain, lingually dentin porcelain, into that veneer to match that color. And I'm working again with my paste here, with a bronze color, silver color paste, to match the anatomy, match the morphology and surface texture. I'm using customized stumps basically to match the color as good as I can, especially that also the case with Miles. He's hundreds of miles more north than me here to make a veneer fit, and that was the result, and the patient was very, very happy. I still see the veneer slightly higher in value than the tooth next to it, Also, you see there are some chips in that tooth. The patient didn't want to have that copied, and we asked him, or should we do a veneer maybe number 9 tooth to kind of have 2 veneers matching each other. He didn't want to do that. I heard now he's now ready to do it. So, but besides that, it was a pretty good outcome. You don't see any graying. That's why I want to show here in this area where basically nothing is supporting a light transmission. Yeah, everything is blocked nicely from the dentin from behind, and it has a very natural appearance basically. So that's very important to understand. So now I can say, well, but that's dump, and then we have just 2/10 of material there, and that chunk of material on top basically that will break, right? So why should it break? If you look into natural dentition, how strong is a natural tooth? I would ask you this now, and I would love to do a poll. We don't have time for that, but think about it. How strong is natural tooth? Google it. We're all online right now. Yeah, natural dentition in compare to lithium silicate. We talk lithium silicate. We talk about 450 megapascal. 450 megapascal. People say, "Why it's not strong enough? I need a super strong crown." In compared to natural dentition, which is 130 megapascal, this is almost 4 times as strong. That's a crazy amount of strength what we put on there. So therefore, I would always say, yeah, man, of course, that veneer with 450 megapascal strength, that will withstand more than most likely a natural tooth on stress and bite force, etc., etc. So that's kind of what we're working here with. Yeah, if we then think about this, zirconia is 1200, 1300, 1400, 1500 megapascal in that range. The lower translucent zirconia, even the high translucent now, that is almost 10, actually it is 10 times the strength of a natural tooth. So we sometimes overbuilding our restorations in strength we don't actually need. We maybe even can harm the underneath structure with a too strong crown. So we have to be careful. Yeah? So therefore, a 450 megapascal strong restoration is definitely strong enough for a veneer, for a crown, etc., etc. Not for a bridge. We talk about individual restorations. So now, talking about bridge, right? Let's talk about something more complex. Something like this. These are restorations I like the most to do right now in regards full mouth or full arch reconstructions. And these are basically, I call it Thimble Bridge. We're creating a framework or a bar with individual preps, having then created individual crowns, pressing them in lithium silicate, and finish everything up with composite in terms of the pink aesthetic. So here we go through. This is design, this is milled. Here I utilized Pecton to mill, and then mill individual wax crowns. I utilized the white wax here from Harvest, and that goes on that frame, and we ship this out to a try-in. That wax is very sturdy, so the doctor can even adjust that wax and can try it in. Unfortunately, the patient sees the white teeth and says, "Oh my God, I love it. I want to have these white teeth." That looks fantastic. I always wanted the white teeth. And the clinician and we both told her, that's not gonna happen. You're not gonna get these white teeth. No. So we convinced her for a lighter color, but not for white. So we tried it in and made some adjustments, and then back to the laboratory. We then actually can take these crowns straight, invest it, and press it in LiSi, GC LiSi Press, stain and glaze, or make a little cutback and layer depending on the restoration, depending what the patient would like to have. Here we just did stain and glaze. And then we're going to finish everything with a pink composite base. We can use Gradia, for example. We use a pink composite to layer it. I usually leave the entire surface of the Pecton blank and polished just for hygiene. It's cleaner, it's nicer on Pecton, on a high performance polymer. Nothing really sticks to it if it's polished. It's very, very clean. So that's why we usually leave that and finish up the restoration as a screw-it-in hybrid and a nice natural look. And that's the patient very happy she liked the color then. She said, oh yeah, that's actually lighter than my lower, so I love it. I'm totally in love with the restoration. It's perfect. So that's kind of how she went home. And you see the gradients we were achieving just with staining glaze. It's very natural. It's very nice, especially with the underneath preparations of that Pecton. It gives a natural effect. It really looks very nice and comes over very, very natural. So another advantage of lithium disilicates in compare to other materials are for complex restorations are on telescopes where I love to do it. Yeah, so where do I use it on telescope restorations? Just in this case as an example, it's a classic case, devastating initial situation. So we're planning on a full mouth rehabilitation. And I don't want to go too deep into the whole telescope discussion. We unfortunately running a little bit short on time. So I want to show you why now we're using lithium disilicate here. So we did the same thing as we did before. We created first telescopic abutments and then created on top of these second these galvano copings and created then our Thimble Bridge. Telescopes is a adhesion fitting prosthesis on primary abutments or primary crowns. So there's no attachment, there's no plunger locking it in. So we have to make sure that restoration is light. And lithium disilicate is light, very light. LiSi is very light. So that's the advantage of utilizing Pecton, which is super light. We're utilizing a crown material like LiSi Press, which is super light, and composite, which is not as heavy either, and can finish therefore a very lightweight, very high-end complex restoration for a very good longevity. And here we see the final case. So these are lithium disilicate crowns on the Pecton, finalized with a pink composite. And you see here the galvano in there and this in the mouth, and seated. Very happy patient. I did this restoration a few years ago. Patient still super happy. No repairs at that point because we have no wear on denture teeth. There are no denture teeth. There are crowns, and it's just a very cool restoration. Very good longevity, and the weight is just very, very minimal. Restorations like this, we decided to do here as well a Pecton Bridge with Thimbles. You see that's kind of one of my favorite restorations. And also same here, we designed crowns, milled the crowns in wax, and then finished the crowns, pressed the crowns in GC LiSi, bonded the crowns to the Pecton frame, and finished basically the restoration with composite. Why to do this on this case? Just because you see the recession we have on the gingiva. We want to have a case which is maintainable over time, so we can actually add to the gingiva if there's more recession. Composite makes that just very, very easy in compared to porcelain, where we always have to be worried about if I put it in the oven after 2-3 years, does it blow up or not, right? Or does the porcelain just fall off or crack or whatever happens. So this restoration is very easy to maintain over the years because I can add to, but I still have the stability and the aesthetic of ceramic crowns. As I have both worlds, I have an easy to maintain material for recessions, for adding on for relines, but I still have the aesthetic and the stability of a crown which doesn't wear, literally does not wear. So that's very, very cool. Another case, Emily, she showed up, and a very good friend of mine, Dr. Fuquain in Dallas. First look on this case, it looks really cool, a nice clean emergence profile. If you go one click back, we see this is really, really challenging placement of these two implants. They're so close to the roots that the GP preferred to kind of refer her to his friend, a prosthodontist, and he took then take care for her. So he basically got her to see here with a little provisional Maryland bridge in her mouth and say, I cannot send you home like this, right? So we have to do something. So he made a quick wax up, made a quick immediate provisional in her mouth all same day that she can go home properly. In the meantime, they also scanned her He also took physical impressions here. Maybe when we work together, we're trying always out that kind of digital analog process. How accurate is it? So we always have confirmation basically. So we do that quite a bit. And then basically the same thing. We did a Pecton framework. Here we decided to press in LiSi Press a little crown splint, because one of the access holes is actually facial, so that makes it easy for the doctor to actually cement this in the mouth. So I don't cement it here in the lab and put the composite on. So I actually put the composite, the pink, beforehand, and then he can cement these restorations in the mouth. He can even just use temporary cement, because he has to be able to take it off, unscrew the restoration, and put it back in. At the same time, we made lithium LiSi Press veneers, also to kind of establish a nice balance in her smile, and everything got delivered. And she was pretty happy. If you see, this is the provisional restoration on the right side there, and in compare, that's the final. It's not perfect, but she wasn't looking for perfect. She was looking for an improvement and for a natural smile. And I think that's what we definitely able to give her with that material. And she was very, very, very happy with that. So that was kind of the happiness, my conclusion from today. We have a little bit, few minutes still to have some Q&A. So if you have some questions, I'm here now, I'm happy to answer questions. And besides that, I would love to say thank you and stay healthy. And I'm here to say to answer questions. Also, my social media handle is here, so I'm happy to see you following me. I put a lot of dentistry on there, but also a lot of other fun things. So do we have some questions?
Thank you so much, Alex. That was such a great presentation, and we loved all of the pictures as well. So I have a question here, and it says, are you pressing these cases? I'm sorry, I lost it. Are you pressing these cases?
If I'm pressing the cases, yes.
On Pecton with MT Ignats?
Yes, great question. So yes, on Pecton, I always use MT. I don't use HT, and MT gives me actually really nice outcome. No, I wanted to say I hope everybody stays healthy, and I hope I can see my friends who maybe were watching today or were here. So I hope can see everybody in person very soon. So we'll definitely have some lectures coming up again, and hope to see everybody soon in person.